Okay, so guys, here we have a 60-year-old female who presented to the emergency department with left upper limb and lower limb weakness with speech difficulties. So we know it is a typical case of cortical stroke. The weakness was noticed 8 hours ago when she woke up from sleep and has not improved since then. So it is persisting for more than 8 hours. By definition, TIA is something which improves within 24 hours, but we all know in reality, in practice, most TIAs improve within 60 minutes. If it is not improving within 60 minutes, it is less likely to improve. So I would certainly take this case as a case of stroke as of now. Okay. Her vitals are normal and ECG shows sinus rhythm. So there is no arrhythmia contributing to the stroke. On examination, power in both upper and lower limbs is 1/5 in upper limb and 2 out of 5 in lower limb. That means upper limb is more affected than lower limb. So if you think about which blood vessel most likely involved here, I would certainly think about MCA, because MCA is the one which is supplying the upper limb and face area, and it is the ACA which is supplying the lower limb area. So I am thinking about cortical stroke first by the patient's clinical description, and I'm mostly thinking about MCA territory stroke. Okay. Now, she has a past medical history of hypertension. So, okay, she's a non-hypertensive. MRI scan shows an infarct. So, when MRI shows an infarct, well, I no longer think this as TI. If there's an infarct evident, it is no longer a TI. In the territory of middle cerebral artery, we predicted already. Okay, what is the next recommended step for this patient? So, basically, what we're dealing here is an acute ischemic stroke in the MCA territory, no longer a question of TI. Okay. Now, in acute ischemic stroke, what is the best thing that we can offer to the patient? That is mechanical thrombectomy. Okay. Is the patient within the window period? Yes, but mechanical thrombectomy will be only considered when there is a large vessel occlusion, right? Mechanical thrombectomy is ideally considered when there is a large vessel occlusion. That means you are talking about internal carotid artery occlusion, or you are talking about the M1 segment of MCA occlusion. In this case, there is no CT angio done, so we don't know whether there is a large vessel occlusion. Okay, because we are seeing an infarct in the territory of MCA, but we don't know whether the block is in the M1 segment or distal segments. So I cannot comment about the mechanical thrombectomy. And to decide about mechanical thrombectomy, I also need a lot more information in the form of NIHSS score, aspect score, right? Modified Rankin score. All that information is not there in the question, so probably that is not something that examiner wants, and there is also no option about it. So remove. The next best thing we can offer is thrombolysis. For that, patient will present within the window period of 4.5 hours. Okay, he has presented 8 hours after the onset of symptoms. So certainly out of the window period. So option D is clearly out. Okay. Now, warfarin anticoagulation is not required as long as you say patient doesn't have anti-atrial fibrillation. So anticoagulation is not needed. So warfarin is not required. Okay. Heparin I might give to the patient for DVT prophylaxis, but not directly for the stroke treatment. So not an option. So what are we left with? Aspirin. So this patient will be simply treated with aspirin. Preferably for first 21 days, dual antiplatelet therapy, aspirin plus clopidogrel. After that, one of them, either aspirin or clopidogrel, coupled with statin. That is how I would manage this patient. Thank you.